Finally. Now we are live. So we will wait a few minutes, 2 or 3 minutes.
Please, can you see me?
So we are going to start in 1 or 2 minutes. Welcome to the webinar on COVID-19 vaccine and UHC in Ghana that is co-organized by the P4H network and UHC2030. We are going to start right now because we have only 1 hour and a half. So I would like to welcome all participants and of course our speaker and panelists for this webinar. I'm Claude Meyer and I am the coordinator of the P4H network. I really would like to welcome everybody warmly on behalf of the 2 networks of the P4H network, that is a global network on health financing and social health protection, and on behalf of UHC2030, that is a global network on UHC and health systems that is led by Marjolaine Nico, and the current webinar has also been prepared by Richard Gregory. And I hope that you will enjoy this session about the experience of Ghana. And this, of course, webinar has been prepared in close collaboration with the Ministry of Health of Ghana and the government of Ghana. And we are happy to have you here with us. I hand over to our moderator today, Francesca Colombo from OECD. Thank you, Francesca.
Thank you very much, Claude, for your words of introduction, and welcome to everybody, to speakers, to you, Claude, and of course to you participants. We're very much looking forward to a 1 hour and a half to share learning, to understand from each other, and really to address a very critical issue, which is the one of leaving no one behind, COVID-19 vaccine equity and universal health coverage. And really what we want to do today is to explore, as countries go through the rollouts of COVID-19 vaccinations, what are the linkages between the vaccination efforts and the broader goal of universal health coverage? Because quite clearly those efforts have a shared vision which cuts across, the shared vision of really looking and leaving nobody behind. And I think as we want to learn about the efforts with vaccination, particularly of people who are the most left behind, it's quite clear that we need to continue to echo the commitments that we have for ensuring universal health coverage, which goes way beyond efforts of vaccination, which have to do with having a solid and strong primary healthcare system, of which obviously vaccination efforts are an important part, but also to ensure that access to services, including for the people not directly impacted by COVID-19, is maintained in time of crisis. And so we want really to hear your reflections and the perspectives of panelists as well as you in terms of the efforts towards vaccination planning, vaccination rollout, or also the logistics aspects that are related to that, but also really trying to reflect a little bit broader on the link between vaccine equity and equity in vaccination, as well as the notion and the vision of universal health coverage. And particularly, I did mention primary health care because that's really the fundamental pillar of having strong, resilient, universal health coverage systems. So what we have today to address this question is an outstanding set of panelists and speakers. we'll start to hear about the experience with Ghana, which has been the first country to receive the vaccines, COVID-19 vaccines, and we'll be hearing from Emmanuel Odame from the Ministry of Health of Ghana and from Franklin Azitu Pekoe, who is from the Ghana Health Services. So that will be really a zoom in into the perspective of what is happening on this country, what are the lessons learned already, what can be some of the challenges as well, the opportunity in vaccinating populations. But we want then to reflect in a broader panel that we have Anne Dinstrand from the WHO, Kitinji Kitahi from AMREF, and Inur Aikubanova from Kazakhstan. So we will want really to reflect on this broader question of the shared agenda for leaving nobody behind, even about questions about strong primary healthcare and financing on primary healthcare, as well as efforts to vaccinate successfully. So what's successful ways to plan for the vaccine rollout? So that's what we'll have today. And so I guess without any further ado, I would like to invite the first speaker today. We'll have a presentation from Ghana by Emmanuel Odame, who's the Director of Planning, Policy and Monitoring and Evaluation at the Ministry of Health of Ghana. Without any further ado, Dr. Emmanuel, the floor is yours. And we cannot hear you. You're on mute.
Yes, thank you so much. Yes, thank you so much for the opportunity. And like you said, it's a presentation, a joint presentation with Dr. Sid Bequin, who's the Director of Public Health in the Ghana Health Service. And this picture is to just let us see what happened in Ghana and how we got our vaccination started. You can see His Excellency the President, we see the First Lady of Ghana, we see the Second Lady of Ghana, and we also see some of our prominent chiefs in the country. Next slide. So by way of outline, we are going to show the links between the UHC roadmap and the vaccine equity drive that we pursue as a country. So that will be the UHC roadmap, the COVID-19 phase 1 subnational mass vaccination campaign, our vaccine financing, and how has Ghana moved towards achieving vaccine equity in the context of UHC. So Ghana as a country defined UHC the Ghanaian way. So Ghana defines universal health coverage as all people in Ghana having timely access to high quality health services, irrespective of the ability to pay at the point of use. So you can see clearly from the Ghanaian definition that access has been qualified with timeliness. It's been qualified because we realize that in the context of emergency care, both public health and clinical emergencies, time is of the essence. And it's just not them having the vaccines, but the matter of how timely it is. And Ghana has also qualified the quality of high quality. So we are looking at, in terms of all our services, how are we able to ensure that we get high quality care for all our services that we provide as a country. And we are also saying that Ghanaian is not averse to payment, but how do we get payment to our clients, irrespective of the ability to pay at the point of use. So in this last part, we are seeing health as a human rights issue, as an equity issue, and also looking at it in terms of our common goods and the fact that the common goods for health has to go to the people with or without the ability to pay. So all this goes into the meaning, and all this came up to make our definition for UHC what it is. So our goal is to ensure increased access to quality essential healthcare and public health services. And we have 3 key objectives. One is to ensure increased access to better managed quality primary healthcare services. And here we are looking at curative care, palliative care, rehabilitative care, mental health, emergency care, and promotive services. So we realized that for a very long time, primary healthcare was seen as poor care for poor people. So the question is, how do we recalibrate it to make primary healthcare smart care for everyone and have everything on the platform? And then the second objective was to look at universal access interventions aimed at reducing unnecessary newborn, child, and adolescent deaths and disabilities. And last but not the least is to ensure universal access to clinical and public health emergencies. So clearly, you can see from our 3 key objectives that the whole concept of public health emergencies, vaccinations, have all been thought through, and it's part and parcel of our UHC drive as a country. Next, please. So these were the guiding principles of our UHC roadmap. We wanted to ensure the target group, the vulnerable groups, were well targeted to ensure that no one is really left behind, as is the caption within UHC. And also to ensure financial risk protection, eliminating all fiscal and financial barriers to access, and building strategic partnerships as key between both public-private sector actors and non-state actors. And this became very handy during the era of COVID. We built almost a whole treatment center with a public-private partnership. And then ensure effective decentralized management and ensure more domestic financing reprioritized to have a more clearer focus on primary healthcare. Next slide. So this is our package of care as we are visualizing it. Curative care services at all levels, preventive care, looking at immunization as we are having the COVID immunization. It's part and parcel of our package of care as we conceptualize it. Growth promotion, family planning, screening in all its forms. Promotive care, health communication, alcohol, sexual behavior, diet. Rehabilitative care, that's institutional rehabilitative for physical conditions. Palliative care, institution-based care for terminal patients. Emergency care, right from the community emergency care to hospital care and mental health. As part of the RECE, we recognize that in the area of palliative rehabilitative, there's quite a lot of work to do, and also even in the area of mental health care and promotive care. So all these are areas of envision as key if we are to have a comprehensive package and to be able to change the dynamics from primary health care being poor care for poor people to it being seen as smart care for everyone. Next slide. So at this point, I'll call on the Director of Public Health, Dr. Franklin Asiedu-Bequin, who will take this aspect, and I'll come back at the very end. Thank you.
Okay, thank you very much. Let me say that Ghana, as part of our plan to have universal health coverage, we received some quantities of vaccines to distribute. Before we talk about the vaccines, I would like to update you on our status as a country. Let me say that this data is as of 23rd of March. And as of 23rd of March, we have done almost 1 million tests. We have 90,166 cases with a cumulative positivity rate of 9.2. And let me say that 95% of these cases have been discharged. And we have 740 deaths, which is very low in terms of the case fatality compared to the African region, which has a rate of 2.6%. Our total active cases as at that time is 2,401. So we have 4% of our cases being active. Next slide. So this is the trajectory of the pandemic in Ghana over the past 1 year. So you can see that roughly we are looking at about 2 waves. So you have this little wave that started last year in March, that got to the peak around June and then came down somewhere in September. And then we kind of plateaued, having an active case of about 800. And then come late of December, we started having the second wave. But let me say that since middle of February to now, we've gotten a decline in the number of cases being recorded. Next slide. So one key way to address the pandemic is to have vaccines. And so we developed our national vaccine development plan. And there were several components that we had to bear in mind. So these key components were about coordination. Let me say that Ghana, in terms of our response, is actually situated at a very high level, where we have a task force that the president actually chairs. So we have a number of coordination activities that exist. So we have the coordination at the national, at the regional, and at the district level. We also have the communication, very, very important to address this era of vaccine hesitancy, the challenges of social media. So we have communication also being prominent as part of our plan. We have logistics and waste management. Let me say that we have a very robust EPI the country, but there are challenges at the regional and the district level in terms of availability of cold chain infrastructure. So as part of our plan, we factored in what we need to get things done. Then the training and the service delivery, our plan was to make sure that we have over 12,000 vaccinators and a reasonable number of volunteers. So all this will require a number of training that needed to be done. And then the data management, we wanted to make sure that we have electronic data system put in place so that we can actually recall when it becomes very necessary. Then disease surveillance and safety monitoring. When we are introducing new vaccines, we need to make sure we have the right record of it so that we can make reference to it, particularly when it comes to safety monitoring. So the last is not the least, is about the research, to be able to have an idea how Ghanaians are easily accepting these vaccines. So these are the key components that we put in our plan. Next slide. So the principles of the universal health coverage were very crucial in our plan. So we looked at clearly access, look at cost, look at equity. Let me say that in order to address the Ghanaian, our initial plan is to make sure every 31 million Ghanaians are vaccinated. But currently, the available vaccines are not being used for people under 16 and pregnant women. So we're targeting 20 million Ghanaians. And we are hoping that all these 20 million Ghanaians will be vaccinated. But we wanted to do it in gradual phases. So we had segmentation. So we did segmentation in terms of geography, segmentation in terms of geography in terms of population. So the risk populations and those who are more likely to have fatalities were the key people that were factored in. So we wanted to start with the hotspots and then gradually cover the total population. So access was not to be limited in terms of location. Let me say that Ghana vaccination is at no cost. The cost is borne by the government and all our development partners. So we do not have a cost that's supposed to be borne by any Ghanaian. In terms of equity, whether you are rich, whether you are poor, whether you're a male or female, our plan seeks to make sure that every Ghanaian is somewhat costed or factored into our plan. So the principles of universal health coverage are clearly well articulated in our plan. Next slide. So the strategy that we wanted to use to address this segmented population was that we were actually starting by population groups and by geography. And based on the location, we're going to use strategies that may include static. So static means the use of hospitals, health centers, or even clinics. And then you have outreach locations, a mobile, camp out, or a combination of these. So the idea is that each Ghanaian will be rated based on where you are located. I think the only challenge is that you may need to somehow move to a vaccination site. But as far as possible, our approach is to get every Ghanaian vaccinated when the time is due. So we are actually making sure that when we have the right vaccines that can take care of children and pregnant women, then the remaining population will be covered. So that is the strategy we were using. Next slide. So these are the detailed strategies that we focused on. In terms of the target groups, we're looking at health workers. These are normally situated in health centers, hospitals, and that, let me say that it's not just public. So only whether you are private or public, you are factored into our plan. Then we also have persons 60 years and above. Let me say Ghana, we have a very youthful population. So for us, 60 years is elderly. So it's considered, and they have to be reached by fixed and outreach sites. And then you have mass campaigns. We also have persons with underlying conditions, commonly persons with diabetes, hypertension, and cancer. These are persons that tend to have adverse outcomes when they have COVID. And there are other target populations we hope to reach by fixed sites. And then we also have to do temporal or mobile clinics and then mass campaigns. So these are the strategies that we have started using and we hope to use for our vaccination. Next slide, please. So because we are not going to get all the vaccines at a point in time, so it means that the access to vaccines is going to spread over a long period of time. We target our population in phases. So the first group is persons who are mostly at risk of COVID. So the one is healthcare workers. And for Ghana, we have over 300,000 workers that are in the health sector. So we have persons with known underlying medical conditions I talked about, being hypertension and diabetes. We have 60 years and above. We have teachers 50 years and above. And then frontline members of the executive, the parliament, and the judiciary. And then the frontline security personnel. So these are our first group that we were focusing on as a country. Next slide, please. Then we have the second group. So these are the other essential service providers, including the rest of the security agencies. So these are persons that work in the water, they work in the electricity. There are other teachers who are below 50 years. And then we have the securities and intelligence agencies, that is the police, the armed forces, the prisons, immigration, the fire service, and the others of the security services. And then the others of the arms of government. So these belong to the second group. And let me say that the third group is actually the rest of the population who are outside the first and the second group. So we have the last group, which is group 4. For now, we do not have vaccines that covers people under 18 or pregnant women. So these are a group that are for now excluded in terms of our current rollout. Next slide, please. So we received our initial 600,000 doses of AstraZeneca. Actually, we had the COVID on the 24th of February as part of the COVAX facility. We are honored that Ghana was the first country to have the first allocation of COVAX supply. And we are hoping to get more additional doses by the end of May. So as part of that initial allocation, we started a campaign in 43 priority districts. These are actually our hotspots in terms of the risk of getting the COVID infection. So these 43 districts are situated in 3 of the 16 regions in the country. So as part of the process, we did a robust active monitoring of AEFIs. So there's a system being put in place. We also have developed jingles. We are using the radio stations, the mobile vans, all to make sure that the Ghanaian is alerted. We're also doing that to address issues about vaccine hesitancy. And let me say that clearly, we have a high level of political, religious, traditional leaders who are all doing a lot of advocacy to promote access. And let me be clear that, as was said by Dr. Odame, this picture clearly depicts our president. He's our #1 advocate for vaccines in Ghana. So he was the first person that actually took the vaccine to energize the Ghanaian that the vaccines are safe and efficacious. Next slide. So as of the 25th of March, we had actually vaccinated 487,000 persons using the AstraZeneca. And in terms of the gender, Ghana, we have more females than males. So we have 52% of females being vaccinated as against 48% of males. Greater Accra, which is the main epicenter, that also has more of the districts for vaccination, had the highest number of persons vaccinated. So they had actually vaccinated 275,633 persons as at the 25th of March. Next slide, please. So in terms of details, you could see that clearly Ashanti region had vaccinated almost 200,000. Greater Accra has vaccinated 275,000. And then when it comes to male and sex, females are dominant. They have vaccinated 251,000, almost 252,000. And the males are vaccinated 235,000 persons. Next slide. So this is a pie chart of the distribution of male to females. This is what proportion of our target locations have been covered. And clearly, if you look at this slide, you can see that by way of our projections, most of the locations or the communities were reached. As you can see, prominence of Kumasi, that has about 6% of them being reached. And then, so clearly, you can see that our coverage was very good so far, and we are on course. Next slide. So this is the distribution in terms of the region. Like So you can see 57% of the cases of the vaccines were actually received in Greater Accra, 41% in Ashanti, and 2% in Central. Let me say that Central had only 2 districts being covered as part of this 600,000 doses. So that's why they have this limited supply of vaccines. Next slide. So which category of persons have been vaccinated? I think that I said that for our group 1, it's about health workers, it's about persons 60 years and above, it's about persons with underlying comorbidities. So somehow roughly, if you look at our coverages or our performance as at now, the highest persons are persons 60 years and above. Then we have the general population. Let me say that there were initial challenges of our vaccine hesitancy. So though we had clearly outlined persons in terms of the first group, we somehow allowed others to also make sure that they also get the vaccine. So general population, that's excluding persons less than 18 years and pregnant women, also have almost 100,000. We have health workers, that's inclusive clinical and non-clinical, private and public. We have about 75,000. We have persons with underlying conditions, also having about 66,000. And it goes further down to the media. Let me say that the media is very, very important in Ghana. One, they set the agenda so that people have clear buy-in about the safety of the vaccines, so they have a reasonable number being vaccinated in the first phase. Next slide. So what were the means by which people got to know of the COVID vaccine? And let me say that this slide clearly tells us that television and radio are the main sources of information that got us to know about the vaccine. Let me also stress that these areas were more of urban. So it clearly tells you that in urban areas, TV and radios are very crucial in terms of information sharing. Next slide. So I think that's all for now. So Dr. Odami, you can take over from here.
Thank you so much, Dr. Silva Queen. So by way of the macro picture, just to highlight a few things, that clearly we've realized that COVID and its implications has had a major impact on the country that we cannot run away from. In 2020, projected GDP growth was estimated to be 6.8%. As of March, when COVID hit Ghana, we had to do recalibration in July, which brought our real GDP growth to about 0.9%. When we started easing restrictions somewhere in October, we recalibrated back to about 1.9%. So clearly you can see that there's a clear link between COVID and its implications and how real GDP growth has played out in the country. So really health and its implications on other sectors has been demonstrated visibly through this COVID and the pandemic and its implications on the economy. We had also done a study and doing some projections showing clearly that there was going to be a downward trend in external financing to 6 sectors, of which we included immunization from about $198 million in 2017 to about $90 million in 2025. And even these projections were done without the knowledge of COVID coming into being. So clearly, the financing implications of COVID on the health sector and implications of it are key. And this is where the whole area of donor financing is also coming in key. How do you really align donors going into the future? And we've mentioned a lot around SDG GAP, the Global Action Plan, Engage, Accelerate, Align, and Account. Many actions we've done in the past, but really how do we align the many donors that we need to bring onto the fore if we have to take care of this? Ghana did an initial costing that came up to about $270 million, and with a deployment plan of about $52 million. And the deployment includes the logistics, the communication, and all the various things that have to happen around the country to ensure that we're able to move it forward. And we also aligned supply challenges around the world. So we look at the COVAX platform. Dr. rightly stated, we received our initial 600,000 doses, and we are expecting more. We are also working with the African Union, African Medical Supplies Platform. So these are all the multilateral platforms. Actually, a few weeks ago, we just got about 165,000 through the MTN Foundation. We are working with also private partners who are also coming on board. So the message here is that Ghana is working with both multilateral and bilateral sources in trying to bring in vaccines into the country. We're also looking at donor partners, the World Bank. We try to work with them on a package to see how they come in to support. Central government is also directly also working on itself to buy some of these vaccines for itself. Actually, now 2021 budget, we put a 1% levy as a COVID levy on all goods and services. Just to us to raise enough and adequate funds to be able to take care of most of these things and also work with partners to augment government efforts. And as Dr. Silbeck rightly stated, His Excellency the President really coordinates all these efforts in Ghana. So we have full central government control in terms of how these things are done. Next slide. So how has Ghana moved towards achieving vaccine equity in the context of UHC? As was rightly stated, principles of UHC are driving our vaccine rollout in access and equity. So clearly, the vaccine rollout is not a siloed approach by being driven within a broader UHC context, as in the UHC roadmap, which is driving all these various actions, as it were. We've had to deploy drones to improve access by reaching hard to reach areas. There are parts of Ghana that live in riverine communities, island communities, and these communities are being targeted with the drones to ensure that they also receive vaccines, just like any other person who lives in any other part of the country, and ensure that there's equity across board in all parts of the country. We're also alive to the fact that we are in the IoT, Internet of Things generation, and the power of ICT to capture real-time data is key. So we are leveraging the power of ICT to capture real-time data for all the ones who are being vaccinated. And we're also looking at health from a more comprehensive approach. We're also leveraging the potential of traditional alternative medicine and see how best this can also be augmented in the battle that we are pushing ourselves towards. We're also refocusing government primary role from sole service provider towards the worship of the overall development of the health sector. And last but not the least, we've also realized that the health system architecture has to be relooked at. And that moving into the future, we are looking at our primary healthcare systems. How do we move it into a network of parties? So our health system starts from the community level, the health center level, and the district level. We're looking at a system where all these levels will come together into a network of parties to provide all the comprehensive services, right from preventive, curative, rehabilitative, palliative. And in fact, looking at the future where we can even credit these networks. So this is the kind of design features we are trying to bring around our primary healthcare system, so as to move the rhetoric from poor care for poor people to smart care for everyone. Next slide. So thank you so much. And this picture just gives you an idea of what our many health workers across the country are going through in trying to bring vaccination across to all parts of the country. And thank you once again. Bye.
Thank you, Emmanuel Franklin. That's really fantastic, your presentation. And wow, there is a lot that some of the very advanced OECD countries could learn from your approach. I mean, there are lots of keywords that I can think of. I mean, the alignment that you have, your agenda of vaccination with a universal, truly universal health coverage agenda, the idea of leaving nobody behind, thinking through the prioritization processes, obviously in the context of resource being scarce, and how you do that in a way which is the most effective and equitable. I think there is the comprehensiveness of your approach. I mean, your definition even of universal health coverage is very comprehensive. It includes everything, including palliative care, the mental health, all fundamental components. And I think the way you're applying your plan, which includes, also data, communications, again, equity, both in access and in financing, really quite a lot that countries at all levels of economic development can really learn from. So without any further ado, we can move now to the second part of our agenda, but I'm sure that there will be some questions to you as well later on, about your really impressive efforts. But let me move now to the second part, which is really a panel discussion, and I'm very, very excited to have three wonderful panelists with us. We're going to ask each of them to address in turns, and then again there will be parts of the broader discussions later on. And I would like to start with Anne Lindstrand, who is actually from WHO. She is actually the head of units of the expanded program on immunization, so could not be a more welcome person to talk to us today. And she's very involved in the COVAX facilities. we're really very much interested in understanding how COVAX is really working to support countries as they roll out their vaccination plans. What do you think this might be linkage to the broad notion of, again, universal health coverage, but particularly primary healthcare services? And so are there lessons learned from the short term, but also more broadly for the medium long term? Over to you, Anne.
So thank you so much. First of all, I just wanted to say a huge congratulations to Ghana. I really enjoyed seeing your presentation. It's very, very obvious that Ghana has both high ambition for universal health coverage and ripe plans and thinking across that, but also that you could see that the initial rollout that you presented has been very successful in the preparations and the delivery of this first range of COVID-19 vaccine. You were the first ones to get vaccines from the COVAX facility, and you've done an exemplary rapid rollout and comprehensive thinking around delivery strategy, target population, etc. I think that some of it, this success, some of it, can be attributed to your strong EPI program and solid EPI program from the start. And as you said, that's where the basis of your work was and how you delivered and prepared. I also very much enjoyed the principles that you laid out on both access, cost, and equity, because that is actually the full foundation of why COVAX facility started to make deals, procure, and deliver vaccines across many low-income countries. But let me just step back just a very little while. It's obvious that this pandemic has disrupted so many pieces of health systems and immunization systems. The pandemic is not over, and it will be with us for quite some time still. And the decisions made by leaders and citizens right now will determine the acute phase of the pandemic, if it will end or not. And vaccines, of course, will be a critical tool to battle against the COVID-19 vaccine. It's been fantastic the past year to see how the world have come together to manage and clinically trial all these new vaccines, and that they are now at the delivery phase. As of a couple of days ago, there were about 450 million doses that had been distributed to around 180 countries. And this is absolutely extraordinary, a fantastic world achievement, and never ever seen speed and scale of a vaccine introduction before. The COVAX facility, with work from WHO, UNICEF, CEPI, and Gavi, have tried to secure 3 billion doses, and the ambition is actually increasing to reach even further, more than the initial 20% that was hoped for in the COVAX facility, as countries like Ghana has higher ambition of reaching more populations than just the initial highest risk populations. COVAX have so far delivered about 32 million doses to 6 countries. So what we worry about now is that the delivery has slowed down. You said you're expecting the next batch from COVAX, apart from your bilateral and other ways of getting vaccines from COVAX, in May. And other countries have actually had to wait. I think we are about 20 countries who are not reaching the target that the DG wanted, to reach all countries who wanted vaccines in the first 100 days of this year. And so far we can see that due to supply constraints and manufacturing capacity and other reasons, some kind of, maybe 20 countries will have to wait for beyond those 100 days. I work, as you said, Francesca, both in COVID-19 vaccine delivery at the moment, but my heart and my main work is actually in EPI programs. And from the initial phase of the pandemic, we have monitored the disruption of immunization programs, and in all regions in support of countries actually do collect the data and follow up, what is happening to the regular immunization programs. What we do not want to see in this fight against the pandemic, in this massive, never seen rollout of COVID-19 vaccines, is that we forget about the regular immunization services or health services, the primary healthcare services. We know that resources are pulled out. We know that costs are immense to be able to do this rollout. And it was good to see the calculation from Ghana, actually, and the massive amount of funding that is actually needed to get both the access of the vaccines, but also having the operational finances to roll it out. The increased demand on health services for health workers to deliver these vaccines will be a massive challenge for many, many countries, which already have a huge HR gap in healthcare workers and staff, just to be able to do all the things that is needed in the rollout. What we worry about in this complexity for 2021 is when the doses ramp up more and more of COVID-19 vaccines, the strains on healthcare systems, on the cost for governments of the rollout will be very, very high. So in the fall, Q3, Q4, when there will be more and more doses out, and the high ambition by so many countries of wanting to reach, as Ghana, many more than just the initial most high-risk populations to be able to fight the pandemic. There will be a competition, and there will be a competition of resources, of the healthcare workers, and we do not want to see that the price we pay for that is increased measles outbreaks, diphtheria outbreaks, and malaria increasing again, TB increasing again. So we need to have a split vision at the same time, I think, across all countries of the world, of maintaining our immunization systems, our primary healthcare systems, and at the same time being able to manage this rollout. And it is a fine balance when it comes to the principles that you laid out, or access, the cost, and the equity. We in WHO and the COVAX have been very strong on saying it is about time for all countries of the world to donate doses, be able to share doses. So those countries that wants to now roll out the COVID-19 vaccine can do that at a reasonable cost with a lot of support. And it's not only the COVID-19 vaccines that we need in the fight against the pandemic. It's also life-saving therapeutics. It's also the diagnostics, and it's also the protective equipment that is needed during the time of the COVID-19 vaccine rollout. It's really extraordinary how countries will be able to fight two fronts at the same time, you can say, and be able to maintain the essential health services. In immunization, just to wrap up, in immunization, we are worried about the disruption. We are impressed by African region who've been extraordinarily resilient in upholding immunization services so far. But we are worried that as the doses ramp up, that will be more and more difficult. The immunization world has recently made an immunization agenda. It's a vision for the world, the next 10 years. The World Health Assembly will be discussing this. And one of the main focuses is the zero-dose children and the zero-dose communities. Those communities that are furthest away, that are rarely served by immunization, primary healthcare services. This agenda is called Leaving No One Behind, an Immunization Agenda 2030. Of course, during the pandemic, the weaker systems have been affected more than any others. And the weaker parts of any primary healthcare system is also affected most. And it will be needed a dedicated effort from all countries to actually reach those zero-dose communities, both for maintaining immunization services and for the rollout of the COVID-19 vaccine.
Yeah. And thank you.
Yes, thank you. I just wanted to say that there are opportunities as well. Digital tools, rollout at the same time, resources coming at the same time. So let's use them the best possible way to both support the rollout and the immunization and the healthcare systems. Thank you.
And thank you so much. Very important point, including your last one. The apologies, I'm trying to get and keep with the time, but absolutely. Are there any innovations, way to do things differently, leveraging technologies such as digital that can help? But a very, very important point about the disruptions into other immunization programs and more broadly into other also services. And if we truly have a universal health coverage lens, it's quite clear that we want to make sure that we don't address one issue to create problems elsewhere. So how to find that balance and keep that, equity and universal health coverage principles front and center. Without any further ado, I would like now to go into discussion also and hearing from the community also perspective. How do we engage very much the communities? And I think we could not have a better person than Gitinji. Gitinji, former chair of UHC2030. He's the CEO of AMREF in Health Africa. I presume many of you will know him. That, we have heard quite well, loud and clear, the experience of Ghana, but what is your reflections more broadly, even from the perspective of civil society, about how to achieve equity in vaccinations and more broadly, how to link to the agenda universal health coverage? Gitinji, the floor is yours.
Thank you, and I hope you can hear me.
Yes, wonderful background as well.
Thank you. Yes, and my background is representing the communities I'm speaking about. That's a mother and her child at one of the facilities during the COVID-19 pandemic. And thank you, Francesca. And I'm really impressed by the work that has been done by my colleagues in Ghana. And the one thing I can say to Franklin and Emmanuel is that we are watching. Many countries are watching Ghana as the first country to get the vaccines. And also based on your very rapid scaling of vaccination, because again, we say vaccines don't save lives. It is vaccination that saves lives. And getting vaccines from ports to arms is our single most important agenda so that communities can actually benefit. Because at the end of the day, it's about saving lives. And it's not about vaccine distribution, it's about saving lives. I will share, that more recently, just about a week ago, I lost a very close friend of mine who had lupus. And every time we talked about COVID, she said, I am looking upon you to ensure that when the vaccines arrive, I get the first dose because I want to save my life. But the vaccines came too late for her. And by the time the vaccines came and we were able to distribute, especially considering the priority lists was more focused on health workers and essential services and teachers, she missed the vaccine. And now we've had to actually lose. Do we think of this as saving lives rather than just a supply chain issue? Of course, we know that universal health coverage is critical, and we've talked about universal health coverage consistently, about it being a critical element of global health security. And this means that we are providing all services to all people without financial. What I would like to reflect on is, what are the challenges? And Francesca, you let me know if I can't be heard, because sometimes the network is unstable. So I'll watch you, and if you can't hear me, you just shake your head. But I would like to talk about how do we ensure equity within countries and also between countries. The first thing, when I look at the Ghana plan, which is very, very well done, I want to reflect on one, that when we are talking about access to services, all services for all people, it includes preventive services, and that's COVID vaccination. It is not about vaccines we knew before. It's about protecting all people and providing them all services when they need them. So people need preventive services now of COVID vaccination. And what we've seen actually is that many people saying, well, for COVID services, we are not going to cover that. Even for national health insurance schemes, even for private insurances in countries, we've had them say, oh, for COVID, we are not covering your services because that's an emergency. And also for vaccines, that one we can't cover because it is emergency. So I think there's a big issue there about affordability. If I look at the Ghana plan, I've done some quick calculations at the back of my envelope, and I've found that what Ghana is looking for is actually $8.8 per capita to execute its plan. $8.8 per capita when you look at the total population. If you look at just the 20 million people they want to vaccinate, it is $13.7 per capita. Now, Ghana's government expenditure on health, give or take, Emmanuel might have the correct numbers, but it's anywhere between $30 to $40 per capita of government expenditure on health. Now, when you look at $13.7, you're basically saying that 40% of the annual per capita expenditure should go to vaccination if Ghana was to afford to vaccinate the 20 million people within a year. That's practically not possible, because it means that you're going to crowd out all the other services that Ghana needs to offer, even within a suboptimal budget already. So we are saying that for equity to be achieved, it is not a national, it's a national responsibility, but it is most importantly a global responsibility. That actually we need to look at equity beyond the domestic resources, because as you can see, if we are to protect the world, it's not going to be possible for countries to use their per capita expenditure now to include vaccination, whereas UK can do it at $4,000 per capita, and when countries in Europe, $4,000 per capita per year, adding $13, $20 per person, it's okay within the 4,000 expenditure. But for African governments, it is almost 40% of your normal health expenditure. Not possible. So we have to think about these issues when we are talking about equity between countries. How do we ensure that, because there's a global health security issue, that is not only a national responsibility, it's a global responsibility. The next issue is to talk about, therefore, the role of multilateralism and global responsibility. And this goes beyond just financing COVAX. It goes to also ensuring that if indeed we believe that none of us is safe until everyone is safe, how do we then go back to the CTAP, to the Vaccine Equity Declaration of WHO, and say that countries and manufacturers need to accelerate sharing knowledge so that we can accelerate vaccine manufacturing? We are now seeing problems in India with the Serum Institute saying that they can't release doses until they have enough for their own country. How can this be when we are talking about global responsibility? How do we ensure that we accelerate production by releasing intellectual property? That can be the most important global agenda right now, to ensure that there is equity between countries. Even as we talk about countries holding doses up to 5 times their population, the bigger effort should be in releasing intellectual property to ensure that more manufacturers can manufacture these vaccines so that they're available for everyone. And the final point is on in-country equity. We are seeing challenges here that when the vaccines come, because of the challenge of supply chain availability and push through or getting sure the vaccines are available, who are we considering as priority groups? It is fine that we can consider, we have 2 dimensions. We are looking purely at risk of infection, that is health workers, and we are looking at risk of hospitalization, which is basically the elderly people. But where is the dimension of equity? Where are the refugees? Where are the prisoners? Where is the dimension in the prioritization of access that we need to add a dimension of equity in this prioritization framework that came largely from SAGE? How do we ensure that we have equitable access? And the final point I want to talk about, Francesca, is community trust. We are seeing that hesitancy is higher where community trust for government is low. And we must work together with civil society, community health workers, religious leaders, and local leaders to ensure we build community trust, not only for vaccines, but for everything else, including disease surveillance, which is critical for global health security for this pandemic and future pandemics. I would like to stop there because I'm sure there'll be questions, but I'd also like to thank my colleagues from Ghana for a very job well done in scaling up vaccination. Thank you, and back to you, Francesca.
Thank you, Gitinci. You covered lots of grounds. The issues of trust that you mentioned at the end, fundamental, you know, trust, community, trust in politicians as well, trust in the process. The fundamental issues of equity from a multi-country perspective, the multilateralism, making sure that there is sharing of knowledge for productions of vaccines. I think those are very important efforts. There is a global responsibility, as you mentioned. Thank you so much for addressing those points. And we right now to the last but not least, a perspective from Kazakhstan, because quite clear if we're talking about you know, issues about vaccinations, issues about universal health coverage, primary healthcare is very much the core pillar of a vision for universal health coverage. And we're very delighted to have with us Ainur, and I hope I can pronounce your name correctly, Aitkanova from Kazakhstan, who is the current Director of Strategy and Development in the Ministry of Health Care of Kazakhstan, and who has been really being a leader in trying to push the agenda for universal health coverage. So Ainur, the floor is yours.
Hello, everyone. It's a pleasure to be part of this very lively and interesting discussion with a very diverse perspective, both geographic and policy standpoints. So yes, you pronounced my difficult name correctly, Francesca. Ainur, first name, Aitkanova, last name. So yeah, in fact, my last name maybe reflects the influence of the Soviet Union when most last names had to have that ova or ov suffix added. So let me just start with Kazakhstan's kind of unique background with a strong emphasis on primary health care. So in Kazakhstan, as you know, in 1978, the countries have adopted Alma-Ata Declaration. Recently in 2018, we had renewed the global vision on primary health care by adopting Astana Declaration. And I'm very happy to recognize some of today's speakers, namely Mr. Gitinci, as also we met during that conference. And just to add some in-country perspective, since 1991, independence of Kazakhstan, we have adopted like every 5 years, sometimes 4, sometimes 6 years, but average 5 years, strategic health plans. So like health strategy plans were reviewed every 5 years, and all of them included primary healthcare as the foundation of health system strengthening. So it's interesting, I personally analyzed the content of our like 5-year plans since independence, and there is none of them that didn't place strong emphasis on primary healthcare. And as a result, in our country, we have basically maintained the strong emphasis on PHC since like Alma-Ata times. For example, geographic access is ensured by primary healthcare facilities, which are in urban areas called polyclinics. From the word poly means multiple, like it doesn't house only GPs or general practitioners. It also houses specialty physicians and serves as a one-stop shop for different patients with chronic diseases, including labs and including maternal prenatal care and pediatric care. And in rural areas, we have geographically divided our large country, which is 9th largest in the world and scarcely populated. So the problem in rural areas is typically access to care, but still we geographically divided the entire country by between rural hospitals. So rural district hospitals serve a particularly defined geographic area, and a rural hospital also has two individual PHC satellite offices. It could be a small nursing office where served by just one nurse who provides primary care, including vaccinations. It could be a felcher or so-called physician assistant office served by that one particular healthcare worker with his own facility like it's maybe a small room or 2 rooms equipped accordingly, or it could be a physician's office, which is part of the rural hospital. So basically, even in rural areas with, so to speak, expected geographic access problems, we have found some solutions by ensuring that every citizen has a particular rural hospital in a rural area to which he or she belongs, and to where they can get free medical care, which is paid by governments, universal health coverage scheme. And so vaccination is conducted historically in so-called vaccination rooms, which are established in primary healthcare organizations. So as I said, in cities, vaccination rooms are part of the polyclinics, the basically primary healthcare clinics. In rural areas, vaccination rooms are part of these rural hospitals, which geographically serve entire rural regions. And so this, we have today 475 vaccination rooms, and our Ministry of Health has very good access and planning based on this network of vaccination services, which are operated through primary healthcare providers. Currently, we vaccinate about 60 people per day per vaccination room. And this is considered average or low load. We could have a higher intensity of vaccination rate if more vaccines are available. And so right now, if we move to the COVID-19 related challenges or issues, we have a limitation to vaccination supply, because the only vaccine that's currently administered in Kazakhstan is the Russian Sputnik V vaccine, which we not only acquired directly from Russia, since like last year, June, there were political agreements between our countries, since we're neighboring countries, and also historical, cultural connections remain. Also, we have production started in our own factory in Karaganda, big industrial city, to produce the Russian Sputnik V vaccine under direction of Sputnik V, producing, and scientists who come and visit Kazakhstan from Russia and ensure quality standards are fully implemented. In addition to this vaccine, we also are in the final stage of approval of our internally developed COVAX vaccine. COVAX is a locally produced vaccine, which was developed. In fact, we had several types, but only this survived all of this, quality controls and checks. And COVAX is expected to be released and available for our market in second quarter of this year. So these 2 vaccines are basically the only ones for which we already have written commitments and payments made. We also have some humanitarian aid vaccines which are expected from China. The Chinese vaccine will come, but that's just ad hoc, humanitarian aid gesture from another neighboring country. We have neighborhood with China geographically. So those are the sealed deals. Also, there are conversations with Moderna and Pfizer producers, but those are only still in the air, basically no clear commitments made so far. And in terms of vaccination rates as of Friday, 26th of March, we only basically have administered dose 1 to 121,000 people, and dose 2, which is complete vaccination schedule, to 30,000 people, which is very little. It's only 0.2% or 1/5% of the entire population of Kazakhstan, whereas we have an ambitious goal to vaccinate 60% of the population. And as I said, the current constraint is vaccine availability, but since April, we are expecting large arrivals of Sputnik V vaccine from Russia, plus our internal Kazakhstan-produced vaccine should also reach the market soon. And so based on that, we will increase the current limited group of vaccinated people, because currently we only vaccinate medical workers like doctors and nurses, teachers, police workers, and diplomats. Since April, we'll add to that all general population who come at will, plus chronic disease patients, plus certain additional services like state employees. And so this will, to enhance vaccination rates, we will also, we have planned through electronic portal called eGov, electronic government, that employers or any companies can invite vaccination mobile team to their employment site. So legal entities like companies, organizations can file an an application, and the primary healthcare team will visit such employers and vaccinate people on site, which will basically speed up the process. And so based on that, now primary healthcare organizations are increasing their staffing capacity and training additional nurses and staff to ensure the demand is met. Also about financing the whole thing, because vaccination is provided by primary healthcare organizations. I want to touch base about financing primary healthcare. When we calculate, there are different approaches to calculating primary healthcare expenditure. We include primary healthcare services, the pure primary GP doctors and GP nurses services, plus we include the so-called consultative and laboratory services, which are ordered by GP doctors and provided within primary healthcare organizations or so-called polyclinics. So that's basically specialized outpatient services. They're not like pure GP or primary care services, but for us, we calculate it together. And plus, we also add expenditure for outpatient free drugs. So medicines are provided free of charge to patients who have registered chronic diseases, hypertension, diabetes, and there's a list of 200 types of diseases for which drugs are 100% covered by government, and they are distributed by primary healthcare organizations throughout the nation. And the expenditure for these outpatient drugs is also part of our overall primary healthcare expenditure. So it's not like pure PHC, but still, these drugs are ordered by PHC doctors anyway. And so this expenditure was 48% of all healthcare expenditure in 2019. And we luckily increased that amount to 52% of all healthcare expenditure in 2020. And in fact, we have an ambitious goal to reach this share of such expenditure. Basically, it's primary healthcare and services around primary healthcare to 60% of all healthcare expenditure by 2025. This year in 2021, we have a little decrease of that rate of financing primary healthcare organizations because of COVID. We had to divert some of the budgeted funds from government to COVID-19 related other expenses by 2021. But other than that, we have, as you see, very strong emphasis and reliance on primary healthcare network. Yeah, so that's our snapshot of our basically situation today. In terms of planning for COVID-19 vaccination and communication.
And I know, do you mind wrapping up? Yes, sorry.
Yeah, sure. I was finishing. I just wanted to add that I think in terms of planning and communication, we kind of share similar approaches like other countries, because we recognize there's social media. It can be used as leverage or as detrimental, barrier. We have relied much on social media channels to influence public opinions and trying to increase or at least sustain trust into government and healthcare system. Thanks.
Great, fantastic. Thanks so much for your experience and highlighting the really quite broad definition of primary healthcare also that you have with having multi-practice, the polyclinic, as you mentioned, approach that's fundamental, and the focus really on ensuring that you have the financing. You mentioned also the importance of the delivery, ramping up the capacity. That's quite clear that really to get out of the crisis, we need to ramp up capacities for the vaccines. I think we can open now for the discussion, and I wonder if all the speakers can put their video on so that we can see all of you. There could be questions that come from different people, and we have already some in the chat actually, which for our colleagues from Ghana. So maybe I'll start with those. There is question, I'll mention a couple of them. There is questions about the use of community health workers and to what extent community health workers are used in the delivery of vaccine, which obviously it's a very, very important question of relevance, I presume, for a number of other countries. And also there is another questions about, how you plan to cover people living in informal settlements as well. Whether, that this could be non-Ghanaians as well. How do you plan to address that? Maybe we'll start with those two questions I don't know if Emmanuel or Franklin, who would like to take it.
Then Franklin can start.
Thank you very much. So, yeah, so thank you very much. Let me say that for us, our plan is to get people living in Ghana to be vaccinated. So we are not restricting ourselves to whether you're Ghanaian or a non-Ghanaian. Let me say that we have a clear allocation to the various groups. We've been giving some allocations to diplomats and very organized groups. So I think that what I want to say is that though we have very, very segmented populations, the idea is that so far as you are resident in Ghana and you fit into our categorization, you get the vaccines, and it's free whether you're a Ghanaian or not a Ghanaian. In respect to the use of community health workers, we have always made use of community health workers in our vaccination. In terms of this COVID, we plan to train over 40,000 volunteers. So what they'll be doing is mainly in terms of mobilization. So they will ensure that we get the right kind of persons to be part of the vaccination exercise. The one we have started now, because it's more of an urban settlement, we have used less of these volunteers. But then as you go further down to the peri-urban and the rural areas, you need these volunteers who will actually mobilize the population in their localities to ensure that they come for service. So they are part of our service. And let me also say that in terms of the vaccinators, dominantly is going to be done by a community of nurses who are situated close to people in the lower levels of care. Thank you very much.
Great, thank you very much. And there is another question addressed to Ghana, but I think it's more broad. We can make it broader to address also other countries, which has to do really with the prioritizations. I mean, of course, the prioritization is principle to make sure that those who are most in need receive a vaccine or even health services first. The reality might be that sometimes it might be difficult to achieve for different reasons. There could be practical reasons related to logistics. There could be that some people manage to somehow get through the queue and pass above others. So how can we ensure true prioritizations for the people that needs to be first addressed, the more vulnerable populations, as opposed to the general populations? I mean, that's certainly something that we see even in high-income countries happening, where in theory, it should be people who are above a certain age or with multiple chronic conditions. De facto, it has been very difficult in practice to ensure that equity on the ground. And I wonder if any of you have any reflections they want to make on this point, whether from Ghana or from other geographical perspective. Please raise your hands physically so I can see. Yeah, I see Anne and Kikinchik. Please, Anne first.
Yes, you know that the SAGE and WHO have recommended the target populations, and we have made an assessment of all the national deployment and vaccination plans that have been uploaded to the partners platform, and you could say that the majority of the plans actually do follow the SAGE recommendations of healthcare workers first, the adults, the medical risk groups, and the elderly. However, you do see a variety of other risk groups or less so risk groups coming into being prioritized. It's up to every national government to decide where. Of course, the doses from the COVAX facility, really, we want them to reach those prioritized group from the SAGE from the SAGE recommendations and from the COVAX recommendations. I also just wanted to say that we've done specific analysis on refugees, asylum seekers, IDPs, and migrants, and there are loopholes and there are countries that actually do not serve these groups. And I know there is a very active political pressure from humanitarian actors and others to be able to persuade governments to include these groups also when it comes to the vaccine rollout.
Great, fantastic. And Gitinji, I think you wanted to intervene as well, please.
Yes, I wanted to raise 2 points on this issue of equity and access. And the first point is the conversation around travel certificates and the COVID-19 vaccination certificates for travel. And we are seeing those conversations going on. Just like I talked about the global responsibility and the need for ensuring that vaccines are available, I would say that travel certificates are a no until global supply chain challenges are overcome. Because when you introduce travel certificates, what we are going to see is that the middle class and people who travel are going to do everything possible to take up the vaccines that are available. And that will be a disaster because the people who need them but can't afford them will not get vaccines at all. And the number 2 is that countries that are actually fully vaccinated their people and then introduce travel certificates will really be actually increasing inequality on global trade to those countries that have no access for no mistake of their own. That's the first thing I would like to say. The second thing I would like to say is that obviously there's a big challenge because of the fact that most of these vaccines are under emergency use authorization. And therefore, there is no clear private sector pathway to distribution of these vaccines, especially in countries like Ghana, Kenya, where communities are highly informal. And informal doesn't mean poor. Informal may mean actually there are a lot of people out of the tax bracket, but are significantly capacitated financially, but also don't contribute equitably to the tax system. And therefore, there is need to find a private sector pathway through probably indemnity approaches that actually are going to indemnify and kind of indemnity agreements that are countrywide or global or regional that allow private sector to actually import the vaccines for those who are able to pay, and that can reduce the pressure on government so that the COVAX can then be focused on those populations that need them most. Thank you, Anova.
Thank you, great. And I think WHO is quite clear on the issues of vaccine certificates, that it should not be as a way to, have some people having priority access to vaccinations. In Europe, there is a much bigger discussion about trying to think of a certificate that would, consider either the utilization of PCR or having proof of prior infections or having had a vaccination. But it's huge discussion. The equity implications are really huge. Emmanuel, I think you have your hands up. So yeah, if you want.
Yeah. Thank you so much, Francisca. I really concur with the points Gitingi made about travel certificates. That if we are really not careful, it will lead to wide inequities, and then those who can have access will then take advantage and have access, and that will lead to wide inequities. I think as countries are planning, the big issue that really confront the prioritization is the global supply-demand challenges that will have to be confronted. And I really like what's happening in Kazakhstan, where some manufacturing is going on with some sort of supervision by Russian authorities. I think we really need to look at some of these things at the global level in terms of how we can offload some of this vaccine drive in other countries that over the years have built some level of capacity, and really look at how, because SDGs were very clear about technology transfer. SDG 17 was very clear about that. How do we move that rhetoric into reality in practical ways? So I think we really need to look at this thing and see how we're able to make SDG 17 real. Over.
Yeah, absolutely. I mean, there's definitely an issue about when we have global public goods, how to make sure that those are available everywhere. I wonder, yes, I know actually wanted to get you in, but you raised your hands already. So over to you, please.
Yeah, thanks. I think it was a good point raised. In our basically current world, English language information dominates for decision making. It is ubiquitous in science, in policy making, and there's goods and the bads of that. I mean, the positive is we can all kind of share and understand each other by, using a specific language. But there's a difficulty of actually some geographic regions or so-called local geopolitical context, which is kind of missed out in an English language-dominated literature, including scientific evidence-based literature, but also policymakers' dialogue. So I really appreciate today's conversation organized by P4H, because an example with Sputnik V vaccine is just that. I know that it was surrounded with some political discussions about trustfulness of that by certain countries, purely I would say political based. But like my husband, who is a physician working frontline health staff, he was vaccinated by both doses of that actually Russian vaccine. So I'm like, okay, let's test it at home. And so he, like the first day he had all the mild symptoms similar to like as he had the real COVID in June of last year. So, clearly there are benefits of looking into different geographic regions, inventions. And I think I agree with previous speakers' notion about importance of technology transfer. Other certain geographic regions might not be as good in communicating in English the innovations in healthcare that come up, and that shouldn't be the barrier to actually making such innovations useful and accessible to some nations and countries that could benefit from it. So we are benefiting based on our geographic, neighborhood with Russia, but I think there are other like Latin American countries that are, talking about this particular. This is just an example. I'm not, saying this is for particular vaccine advocacy, but I just think that this is a good point raised. Thank you. Over.
Great, fantastic. And we have 10 minutes left, 9 minutes actually. And I wonder if we could maybe invite all of you to maybe mention a word that for you, the audience should remember following this discussion, things that you think it's really important. If a word is too difficult, maybe just a sentence, but just if you could all just come up with what would be your takeaway message in one word or in a very, very short sentence. Who would like to go first? Maybe Anne.
I think, yeah. Well, the first word that came to my mind was global solidarity. I mean, it's a very much used word, but solidarity for actually everyone globally who needs the vaccine will get it first. The highest risk groups around the whole world. And that is not happening at the moment. Right. The high income countries are using most of the doses available.
So global solidarity, who else wants to chip in with their own? Franklin.
Yes, thank you very much. I think that one challenge that we have now is the availability of the vaccines. There was an issue about vaccine hesitancy, and we managed to convince the populace about the safety and efficacy of the vaccines. But now it appears there's a lot of uncertainty about these vaccines. So for us, that is a challenge. So for us, the issue is the availability of the vaccines to be able to clearly roll them out is issue of concern to us. But let me stress that we are trying as much as possible to ensure that we address the prioritization. We didn't want to use that word prioritization, so we are using segmentation so that we don't overestimate others in terms of others. Thank you very much.
Great, thank you so much. Yes, Emmanuel, please.
Yeah, I think it's increasingly becoming clear that no one knows tomorrow, and that the future is uncertain, is complex, and is ambiguous. So, as was said by this guy who wrote this book on Intel, there are two things that are key: the knowledge power and the position power. We might have the position in terms of I'm director of policy, I'm director of BPI, WHO, but the new knowledge that's coming is being held by very young people and coming from science labs across the world and public-private partnerships, young guys from Ivy League universities. How do you combine the knowledge power and the opposition powers to make sure that the world, which is uncertain and ambiguous, we can navigate it together. And I think there's a world that presents itself. So we really need to work across with young people across the world and see the world as a global village and move from the concept of nation states. Because like was said today, no one is safe until everyone is safe. Bye-bye.
Fantastic. And so a notion really of looking more at the future and trying to bring in together knowledge power with position power, and but trying to address it for the benefits of all who are lagging behind. Ainur, Gitinji, who would like to go? Gitinji first.
Well, I think what I would like to say is that COVID vaccine knowledge is a global public health good. And if we take it that way, then the question is, how do we supply this common public, global public health good of COVID vaccine knowledge? And that, if we approach it that way, then we may be closer to achieving global vaccine equity. Thank you.
Fantastic. So bringing again together the global notion, the global equity, the global public notions too, which is fantastic when you think at also a country level what you need to achieve. So bringing those agendas together seems to be fundamental. And Ainur.
Yeah, I was going to say about solidarity and mention that. So I'll just say then diversity and inclusion as the key maybe words that I think we should practice better at global and national, local levels. Diversity and inclusion are important to make sure that those who need it most get it first. Yeah.
So I think we are all converging. The notion of bringing the global, the national, the local level together really can be achieved through having a true agenda, which is based on the notions of universal health coverage, on solidarity, nobody left behind, the inclusiveness agenda, all of that. In a way, I think we should perhaps not treat the global and the national as something separate in a way, but try to work those through together through really values of solidarities, and universal health coverage is a perfect lens for analyzing all of those, for planning, for even monitoring and assessing our success. We have come now to the end of our discussions, and with that, I don't know if Claude, you would like to say a few more words at the end? No? In which case, well, let me applaud all of you for, thank you so much for your participation, for your active engagement, for the good work. I learned a lot. I think I would like to make sure that I bring some of this learning also when I sit more in fora of OECD, the more high-income countries, and the discussions that happen there, and somehow bring together also that discussion across level of governments. I think is fundamental. After all, universal health coverage is a sustainable development goal. So all the countries are really addressing the same challenges, and you can see a lot of learning at all different level of economic developments. With that, thank you very much for your contributions. Thank you to the audience for listening, for the questions, and looking forward to a possible next occasion to meet all of you. Thank you.